So, according to Cleveland Clinic and WebMD and some National Institute of Health articles, bronchial asthma, which you've been diagnosed with, is what everybody considers asthma typically. So this is basically a lung disease in which your bronchioles and surrounding muscles or like your airway passages can get kind of narrow and occasionally blocked by mucus. And this obviously makes it harder for air to move in and out of your lungs, making it harder to breathe. So this is subclassified into a bunch of different kinds of asthma, whether it's exercise-induced, pediatric asthma, et cetera, et cetera. But typically it's caused by different triggers like allergens. So some people get worse during allergy season. Sometimes it can get worse with exercise for some people with smoke inhalation, whether that's firsthand or secondhand or third hand. Anybody's really susceptible to getting it if you are genetically predisposed, meaning like your family members have it, or if you have allergies or are obese, you are kind of predisposed to having bronchial asthma. It is also shown to be more prevalent in females and in African Americans than other genders and races. And general treatments typically are inhalation of different drugs, but they do offer also oral medications. And these treatments, basically, these medications are divided up into different bronchodilators, corticosteroids, anti-inflammatory drugs, so on and so forth. And most of the time, it's a combination of multiple of these um, in order to help with the asthma. Treatment for bronchial asthma is not gonna make it go away, but basically it's treatment of the symptoms of bronchial asthma in order to increase your quality of life. So, according to a study by the National Institute of Health, having controlled bronchial asthma um, means basically that you have no limitations in physical or day-to-day life or emotional capacity. Um, Capacity is the wrong word. Um, you can have normal social and physical interactions from a daily basis standpoint, no symptoms or asthma attacks, and best pulmonary function possible. Another article by the National Institute of Health states that if you have to use any of the medications that we're about to discuss more than twice a week, then that shows that you do not have control of your asthma. So there are obviously non-pharmacological treatments such as like preventative treatments, so removal of allergens or extra care whenever allergens are in season, the allergens that you know that you have, or if it's an animal, obviously don't go around an animal. Physical training, so getting your body in the best shape possible. So if you're obese, then you need to lose weight. Simply just being active in general can increase your lung function and your bodily functions, which can decrease your asthma symptoms. Um, Educating our patients, obviously, which hopefully we're doing now. Respiratory therapy, so kind of learning how to breathe, one in general, but also like how should you lay down when you sleep if a sleeping position makes your asthma worse, things like that. Stopping smoking or hanging out, like being around smoke as least amount as possible. And then obviously our pharmacological treatments are separated kind of into categories. We have relievers, which are kind of our fast acting, shorter duration medications. Again, it is recommended by research that inhalation has the best and quickest effect. So, our main inhaled reliever drugs, we use the acronym SABA, SABA, for short acting beta agonists. So this just means that we are using a rapid acting beta-2 sympathomimetic agent. So this is like what you see in like a normal inhaler. So albuterol, terbutaline, and like your hallmark would be your salbutamol. Salbutamol specifically has an onset action of 5 minutes or less than 5 minutes, so it takes less than 5 minutes to do its job, which is to um, open up your airways and decrease your mucus production. And the therapeutic effect of the short-acting beta agonist is about 3 to 6 hours. And then we have our secondary relievers, which are kind of anticholinergic, and our rapid-acting theophylline, which you can get in solutions or drops. Again, always better to inhale it, but occasionally oral medications are required. And then controlling or preventative measures or like maintenance are typically taken more often and almost like a prescription drug, kind of where it would be like take this 2 times a day or whatever, or use your inhaler first thing in the morning. So these include our corticosteroids and our long-acting beta-2 agonists, so LABAs, LABAs. Again, these are in conjunction with inhaled corticosteroids and typically have a greater efficacy when used in conjunction with the SABAs rather than when they're by themselves, as well as vice versa. The SABAs are better when they're in conjunction with LABA, but not everybody necessarily needs the long-acting beta agonists. So for the LABAs, they have an onset of over 5 minutes, so take a little bit longer to start working. However, they do last for about 12 hours, and they're typically used when symptomatic treatment fails. So when the SABAs fail on their own, they then add in the LABAs, and hopefully that works. And if not, then they go from there in treating it differently. So for us, since we are having a kind of a newer diagnosis, we're going to try some short-acting beta agonists. So let's say your albuterol, your typical inhaler, which we would use when we have symptoms or in preparation. So if you know it's going to be a high allergen day for you, or if running bothers you more, then we'll use it right before we start running. You'll take a few hits, which we'll go over how kind of you do that. And then if we find that that's not working for us, then we'll add in a long-acting beta agonist and see if those in conjunction work better for you than just the short-acting. The goal with these is kind of to prevent any impediment into your life and just improve your quality of life. So if we can use a long-acting and a short-acting, and all that means is that if you take a long-acting, then we're taking a puff of that inhaler every morning, and that's just a part of your routine, and then you don't have to worry about it the rest of the day, then great. If we find that short acting works better, it impedes your life just a little bit more simply from the fact of you need to make sure to have that inhaler on you, especially if it's harder to recognize what triggers your asthma or what irritates it. Because until we figure that out, we can't react the same way that we need to. So that can impede your life a little bit, but as long as you have it on hand, it shouldn't be too much of an issue. Some concerns obviously are any allergic reactions to the medication or adverse side effects. And yeah. So like I said before, we'll start with that short acting beta agonist. And if we find that you have a severe level of bronchial asthma and we can't get away with just using the short acting when we need it, then we'll move on. We'll add a long acting in and see if them in conjunction will fix our issues and we don't have to worry about it anymore. Again, like I said earlier, our goal is to make it less than 2 days that we're using that short acting. It might take a little bit to kind of get used to, but if we can get to a point where we're only using that short acting beta agonist less than 2 days a week, then we're in good control of our bronchial asthma.